Excellent. Do you have any plans for an early feasibility study in another cancer type that may occur concurrently with our pilot study? If so, which cancer type would you pursue for a second early feasibility study? And there are a few questions along those lines in terms of another one here asking, thinking about future directions. What's the next study, and do you stick with melanoma? Or could you look at something like squamous cell or basal cell to avoid Mohs? What about non-surface tumors?
Yeah, I'm not sure to what liberty I'm at this point. The answer to that, all of that is, yeah, I'll just say in general, yes. So
Yeah.
we will be into both squamous and basal, both mucosal and cutaneous, in parallel with our next melanoma trial. So the melanomas, of course, the squamous cell cancer is probably more immunogenic in terms of its burden in the system. It's massive. It's readily dealt with surgery in 96% of cases. So, but there is those challenging cases that we are definitely going to focus on.
Mm-hmm.
And of course, the basal cells, which are perhaps even a bigger challenge in that smaller percentage that present. But the melanoma is where all the biology has been born. But melanoma is really the grandfather of all immunotherapy. It's where it all started. And so and this patient population, even though we're excited about all the immunotherapy that's happening now, the response rate is still to single agent immunotherapy in the neighborhood of 30%, 30% melanoma. And yes, up to 50 plus 55% in combination, but the toxicity is absolutely, it's much more. And so this is what we're showing here by this approach, by locally targeting the tumor microenvironment. We are increasing the efficacy significantly and minimizing the toxicity dramatically. And so this is the grail of medicine, biggest effect with the littlest footprint.